This presentation is about focal lung disease number 3, prepared by Prof. Sharaf and revised by Prof. Yusra Sabri. It will be about atelectasis. Atelectasis is collapse or incomplete expansion of the lung or part of the lung. It is most often caused by endobronchial lesion, something inside the lumen that obstructs the passage of the flow of air, either by mucus plug or the tumor mass or foreign body. It can also be caused by extensive compression with a mass as lymph node or peripheral compression on the lung by effusion. So any of these can do. Unusual type of atelectasis is cicatricial and is secondary to scarring, like TB or status post-irradiation. So together, atelectasis is incomplete expansion of part or whole. It is caused by something inside the lumen or something at the wall or something causing extensive compression like lymph node from the central part of the lung or pleural effusion from the peripheral part of the lung. It could be due to cicatricial changes like in post-irradiation or in TB. Atelectasis could be resorption due to something inside the lumen of the bronchus as mucus plug, tumor or foreign body, thus the air will be resorbed and the volume will be decreased, or it may be relaxation if it is due to push from outside like in pneumothorax and effusion. Atelectasis could be lobar and is usually due to an intrinsic central obstruction, that is something respecting anatomy, main bronchus. In adults, it's the most common bronchogenic carcinoma, mucus plugs, or inhaled foreign body. In children, of course, it will be due to foreign body aspiration if you exclude pneumonia and mucus plugs by pneumonia. So mucus plugs and foreign body are the main causes, and then you can add bronchogenic carcinoma in adults. Direct signs of lobar and segmental collapse. Imagine that something is reduced in volume, so the nearby interlobar fissure will be displaced towards that affected part, and the vessels inside this area will be crowded together, and of course the whole thing will show some increased density of the collapsed lung. Mind you that the collapsed lung is more enhancing than the usual lung because of the multiplicity or rich capillary network inside. So a collapsed lobe is usually denser after contrast enhancement on CT. Indirect signs, we have the S sign of Golden, the hilar displacement, tracheal shift, diaphragmatic elevation, compensatory hyperinflation, or shifting granuloma. Granuloma is seen in a location and then you find it changed. The first sign is meant by the shift of fissures. Subsegmental or plate-like atelectasis, linear opacities, perpendicular to the pleural, they call it parenchymal atelectasis or subsegmental atelectasis, usually occurring in post-operative patients, where the diaphragm is showing some impairment of movement for a long time. These areas are deaerated and thus appearing as linear opacities. We have round atelectasis, and in round atelectasis it's formed by a collapsed lobe, which may be with a comet tail sign or pleural thickness and usually associated with asbestosis. It could be, there may be something called discoid atelectasis due to embolus, or could be cicatrizing atelectasis, as we said, near to a parenchymal fibrosis as in TB and fungus. So we have round atelectasis with asbestosis, discoid with embolism, and cicatrizing with TB and histoplasmosis. Right upper lobe collapse will shift towards the fissure, the transverse fissure will shift towards the apex. Middle lobe collapse, it will be gathered towards the heart, causing silhouetting the cardiac border, and at the same time there will be some hyperinflation in the rest of the lung. And right lower lobe collapse, it appears as triangular patch opacity reaching to the hilum, and it is behind the heart. And of course in all of these, because they are lobar, they should reach to the hilum. Left upper lobe, the left upper lobe is a miniature lung. It is the same as the lung but sparing the basal region, while the left lower lobe is usually collapsing behind the heart. So the left upper lobe, because it is composed of upper lobe proper and lingula, they are similar to a miniature lung but sparing the costophrenic angle, because the costophrenic angle is reached only by the lower lobe lateral basal segment. So these are the appearances of the lobar atelectasis. So what's happening here? The left lower lobe is resulting in double density of the left cardiac border, and there is some increase density here, lost radiolucency superimposed on the vertebrae, which should be so translucent like this. That means that there is something in the left lower lobe. And here it is the CT. There is left lower lobe collapse with air bronchogram. Right middle lobe collapse. Here we get it as approximation of both horizontal fissure, which should start here and go anterior, and the inferior part of the oblique fissure, which should start here. The inferior part should start here and go to the costophrenic anterior recess, costophrenic anterior recess. So we have approximation of both fissures, and due to being middle lobe, it results in, and near to the heart, it results in ill definition of the right cardiac border, positive silhouette. Middle lobe, another case, approximation of the transverse and inferior of the oblique fissure with ill definition at the right cardiac border. Upper lobe, right upper lobe, the transverse fissure is shifted up. These are called the golden sign, S sign of golden. Any fissural movement is called S sign. This one is another example of right upper lobe. You have a triangular opacity reaching to the apex, and the transverse fissure is elevated. The right copula of the diaphragm is elevated because of to compensate for the lost volume. Right lower lobe collapse, silhouetting of the right hemidiaphragm, with triangular opacity posteromedial are common sign at the right lower lobe at atelectasis. Silhouetting of the diaphragm, not of the heart. Right lower lobe atelectasis can be distinguished from right middle lobe due to the right cardiac border being well seen in right lower lobe collapse. Here we have hypertranslucency, we have triangular opacity here obliterating this area, and the cardiac border is well defined. That means it is something posterior. The right hilum is also displaced inferiorly compared to the left. This one is pulled down, so this one is pulled down. The cardiac border is still seen, and there is triangular opacity here. That means it is something behind the heart, right lower lobe. Round atelectasis usually seen in, as we said, in what? Round atelectasis is usually seen in asbestosis, and here is the changes in the pleura on both sides. Obliterated right CB angle, obliterated right CB angle, thickening of the parietal pleura here, and something encasing the lung with pussy changes. Of course, asbestosis can cause not only round atelectasis, but also we can find mesothelioma. Another case of round atelectasis in asbestosis, and here you find the pleural thickening nearby. Round atelectasis in asbestosis. Subsegmental plate atelectasis occurring in post-operative situations due to prolonged deaeration. You can see portacath here. So what are the main differentiating points between atelectasis and pneumonia? The volume loss. Volume loss in atelectasis is definite. Volume loss in pneumonia may be increased. There is no shift of the mediastinum and no shift of the fissures or mediastinum. If happened, it will be contralateral to the other side, but if it happened shift, there will be associated shift towards the same side. Opacities in atelectasis are usually wedge shaped. Opacities in pneumonias usually, if it is following lobar distribution, it will be anatomic. Opacities, usually the apex is at the hilum in atelectasis. It does not necessarily center on at the hilum in pneumonia, because pneumonia can be bronchopneumonia, for example, and not lobar pneumonia, and that's why you will not see it reaching to the hilum. But air bronchogram can occur, more evident in pneumonia, but to less extent